I'm Dr. David Schultz, and I'm going to talk about cancer pain management, simple to advanced options. And I'm medical director for neuropain clinics. I'm a board certified anesthesiologist with additional board certification in pain management. And I've been doing this for a long time. I'm pretty old, so I've been doing this for over 25 years. And during that time, I've seen lots of patients with cancer pain. And so hopefully my experience and insights will be helpful to some of the folks who are tuned in tonight. And I've got about a 30-minute PowerPoint, and then we'll open it up for questions. If people have questions during the presentation, you can chat or whatever, and I'll try to stop and answer them right then too. Okay, so first and foremost, why does cancer hurt? And it doesn't always hurt, but it certainly can. And if we know, I mean, all of us here understand that cancer is a complicated disease, and tumors are uncontrollable cell proliferation, and which can invade body organs, which can be very painful. Tumors can metastasize to bones or spine, which can also be painful, and they can invade adjacent nerves, and that can cause nerve pain, which is a special kind of pain that's very intense. And interestingly, cancer treatment can also cause pain. So we see people who have basically had their cancers cured, but they're still having chronic pain related to the chemotherapy, the radiation, or the surgery that was used to cure the cancer. So it's a complicated situation, but cancer is usually and often painful. And if we think about prevalence, about 50% of people who have cancer have pain early on. And if cancer advances, about 75% of patients have pain with advanced cancer. And of those cancer survivors who are essentially over their cancer, or it's in remission, or they're cured from it, 33% of those folks have developed chronic pain related to the treatment that they've received for their cancer. And if we think about just the big picture of what is pain and what are the types of pain, as a pain specialist, I think of pain in two different categories. And there's nociceptive pain. Nociceptive pain is the pain signals that are coursing through a normal nervous system. And so if you think about that, inflammation, fracture, sprain, muscle spasm, tissue injury of any type can cause pain, which is considered normal pain. And cancer can certainly cause inflammation, can cause bony invasion with fractures and other bone type pain, muscle spasms and tissue injury, and all these can be what we consider nociceptive pain. But there's a different category that we call neuropathic pain. And neuropathic pain is special because it's related to damaged nerves, and it can be really more intense and more bothersome than nociceptive pain. It's typically continuous and constant. It's often burning in quality, and it's related to cancer invading nerves that are adjacent to the tumor, nerve compression by tumors, especially in the spine, spinal metastases, or injury from the cancer treatments, and that would be chemotherapy, radiation, or surgery causing some type of nerve injury. And if we think about the most important thing with cancer pain is figuring out why is it happening? Because if it's happening because the cancer is progressing, that's the realm of the oncologist. And all of us who have cancer have an oncologist that we've worked with or are working with. And that's the first doctor that should be involved in figuring out what's going on with this cancer. Why is it becoming painful and more painful? And they would do a thorough history with where's the pain, what are the characteristics, what's the time course, a physical examination, looking for tenderness, neurologic deficits, and then probably most importantly in cancer is advanced imaging, CT scan, MRI scan, PET scan. That can show us if the cancer itself is advancing and needs to be treated. And that's first and foremost, because oftentimes if it's advancing cancer and we treat the cancer to prevent it from advancing, pain will resolve on its own, and that's a good thing. So when a pain specialist like me gets involved, it's typically because cancer has been treated maximally and pain is persisting despite medication management. And if we think about what are the pain relief options in that scenario, well, first of all, most cancer patients respond well to conservative treatment with medications, and they don't require anything further. So oftentimes, we don't see patients with cancer in the pain clinic because they're doing well with their medications prescribed either by their family practice doctor or their oncologist. And if we think about medication management for cancer, there are certainly been thought about and studied for many years. This is the WHO Analgesic Ladder from 1986, which suggested for mild pain, non-opioid analgesics, such as non-steroidal anti-inflammatory drugs, Tylenol, with or without adjuvants. And second step is for more moderate pain, then we would go on to weak opioids like hydrocodone, codeine, tramadol, with or without adjuvant drugs. And the third step is severe or persistent pain of cancer, where we would now start potent opioids like morphine-like drugs, and those would be with or without supplemental drugs. And if we think about adjuvants, which are non-opiate drugs that are helping to relieve pain, that could be acetaminophen, non-steroidal anti-inflammatories, which are powerful anti-inflammatory drugs, nerve stabilizing medications like gabapentin, Lyrica, and antidepressants also have some pain relieving effects, especially drugs like Cymbalta. And amitriptyline is an old-fashioned antidepressant, which is often used in the pain clinic for all sorts of different types of nerve pain. So basically, what I'm saying here is medications are enough for most patients with cancer pain, and we don't see those folks in the pain clinic because they're doing just fine without any pain specialists getting involved. And when we think about medication management, there's the WHO Analgesic Ladder, and I think at least you heard me talk about it, but it's basically kind of common sense. We're starting with non-opioid medications for mild pain, progressing to moderate opioids like Vicodin, codeine, or tramadol for mild to moderate pain. But when pain gets severe, then we go on to potent opioids like fentanyl, morphine, and other drugs which are quite powerful, but they also have inherent dangers, which I'll talk a little bit about. And these adjuvant drugs that we're talking about, these are supplementary drugs that we can use with opioids to make the opioids more effective at lower dose. And that would be something like Tylenol, non-steroidal anti-inflammatories, nerve stabilizing drugs like gabapentin and Lyrica, especially if there's neuropathic pain. And then antidepressants like Cymbalta and amitriptyline. And this is just a diagram of the ladder with mild pain, moderate pain, severe pain with real opioids. And if we think about opioids, and some of the folks on this presentation might be on opioids like hydrocodone is what we would consider a mild opioid, kind of a low power opioid. It's Vicodin. Oxycodone is a little bit more powerful. That's Percocet. That's the active ingredient in Percocet. And Vicodin and Percocet are compound medications, so they have the active opioid in there, but they also are compounded with acetaminophen. Then there's morphine, which is the gold standard of narcotics, really, for pain management. Hydromorphone, which is Dilaudid. Oxymorphone, and fentanyl, which is a unique skin patch type opioid that we use commonly. And there's methadone, which is unique in that it binds to a special receptor called the NMDA receptor. But all of these are called mu receptor agonists. So these are powerful opioids. They all bind to the same receptor in the body, and they all have essentially the same powerful pain relieving qualities. They also have the ability to depress respirations, and that's how people die from overdose. They take too much opioid and they stop breathing because they're not tolerant to it. And all these drugs share those same common attributes. That's why they're scheduled by the US government. And here's just a diagram, some pictures of different opioids. There's oxycodone, which is a very standard first class opioid that we start. And there's OxyContin, which is oxycodone that's time released, just lasts for 12 hours rather than 3 hours. There's fentanyl, which is formulated to go transdermally into the bloodstream, which has certain advantages, maybe less constipating. And fentanyl is also formulated in different types of delivery systems. This is Actique, where it's held under the tongue and again goes right into the bloodstream. So these are extremely powerful, extremely rapid acting forms of fentanyl that are out there and available. And this is Dilaudid, which is hydromorphone, and that's a very powerful oral opioid. And methadone, I said, was unique in that it binds to a special receptor. Methadone is unique in a couple ways. First of all, it's the longest acting of all opioids. And it's not long acting because it's time release, it's simply metabolized extremely slowly in the body. So if you're taking it, you can build up drug in your system over time, and you can overdose inadvertently by taking it for acute pain, and then you're not getting pain relief, so you take another one and another one and another one. All of a sudden, you have drugs that are staying in your body for 24, 48 hours and don't go away. Like oxycodone would be gone in 3 or 4 hours. Methadone will stay there for many, many hours and even days. So it's a dangerous drug in a sense if it's used improperly. So, but it is probably the best opioid for nerve pain because it binds to that special receptor. And then if we think about another class of opioids that are being used more frequently now in the opioid crisis, and these are buprenorphine products. These are called agonist antagonists. And these are drugs like generic buprenorphine, Butrans patch, Belbuca, Suboxone, and Subutex. These are all drugs that bind to the opiate receptor, but they're not as powerful as true opioids like morphine. They're safer in that they have a ceiling effect on respiratory depression. So it's much harder to overdose on these drugs, but they're really not quite as powerful as the true opioids. And they're not used that commonly in cancer pain. Most cancer patients with severe pain are on real opioids like morphine-like drugs. So if we think in general terms, the good side of opioids is that they're extremely powerful, they're easy to use, and most importantly, they don't cause damage to your body's organs. They don't cause damage to the kidneys, the liver, the stomach, the heart, lungs, or any other body organ, even at extremely high doses over many months and even years. And that's something that's lost on some people who don't quite understand that actually, compared to things like non-steroidal anti-inflammatories, which are over-the-counter drugs, NSAIDs in some senses are actually more dangerous than opioids in the sense that NSAIDs can damage your body's organs. They can cause severe GI bleeding, and there are some 16,000 deaths related to NSAIDs per year in the US. There's ulcer disease, and there are cardiac events that happen with non-steroidal anti-inflammatories. And we've estimated that over 100,000 hospitalizations occur per year from non-steroidal anti-inflammatories. So they have their own dangers, and they're not completely safe drugs, even though they're over the counter. Tylenol, acetaminophen is similar in that certainly NSAIDs and acetaminophen are much weaker analgesics than opioids, but they have significant toxicity. So acetaminophen is responsible for 50% of the acute liver failure cases in the US. It's very dangerous to the liver at doses that are over about 4,000 milligrams per 24 hours. And 20% of the US liver transplants are done for Tylenol toxicity. And we estimate that over 78,000 ER visits and 30,000 hospitalizations occur per year because of Tylenol-induced liver injury. So Tylenol and ibuprofen are not necessarily benign drugs. They don't have the overdose effect of opioids. They're not going to kill you by depressing your respirations, but they certainly can damage your body's organs. I think the most important point to take away is that some patients do very well on long-term opioids. And most long-term users of opioids report positive effects. On surveys, 92% of people on opiates, and this is for chronic pain or cancer pain, feel that their pain is well relieved. 57% say that opioids have improved the quality of life. That means 43% say it didn't improve the quality of their life. And some 16% say opioids made my life much worse. So they're not perfect, but they're also very good for some people. The negative side of opioids, certainly the most worrisome issue is overdose, which can be fatal, and that's by respiratory depression. Now, the important point here is that once somebody is on opioids for any period of time, weeks or months, they become tolerant to these effects. So most people that are taking opiates are not going to have respiratory depression because their body is used to it and they don't take too much to stop their breathing. But opioids can also impair mental function. They have side effects which are related to their effects on the brain: sleepiness, mental clouding, confusion. And then there's also nausea, constipation, hormonal imbalances, sexual dysfunction, urinary retention. These are all negative side effects of opioids. And of course, that we all know with the opioid crisis in the US, opioids can be abused and diverted, and they can cause addiction in certain individuals. So let's spend one slide just talking about addiction, because addiction is also a misunderstood phenomenon. And there are two things that happen with somebody on opioids for any period of time. First of all, physical dependence happens if you take opioids for more than several weeks. It will happen to all human beings. And physical dependence simply means two things. Number one, over time, you will develop tolerance, meaning you will need a higher dose of the medication to get the same pain relief effect. So if I start oxycodone today, I might take 4 tablets in a day and get really good pain relief. A year from now, I might require 8 tablets a day, per day to get that same pain relief because my body is tolerant. Likewise, if I stop abruptly, I will have a withdrawal reaction. I'll have sweating, tachycardia, I'll feel horrible. That's opioid withdrawal. And that's another characteristic of physical dependence. Now, addiction is different. Addiction is the compulsive use of opioids despite harm. It's taking drugs to get high. Your whole life is revolving around getting and using these medications to feel good, to get high, not for pain relief. And addiction is only really a problem for a certain percentage of people. It doesn't happen in everybody. Physical dependence happens in everybody on opioids. Addiction, and about 20% of the population is prone to that. And if we think about something like alcoholism, if most people were forced to drink alcohol for days and weeks, they would not become alcoholics. They're not prone to that type of behavioral pattern. They're not genetically predisposed to it. An addiction with opioids is the same thing. Some people can be on opiates for months and years for legitimate pain relief purposes. And if their pain is gone, they'll stop and never look back. Other people who might have even mild pain will take 1 or 2 opioids and it'll trigger a reaction in their brain that just sends everything out of control. They start using drugs to get high. And that's what addiction is. And it's a really kind of a poorly understood phenomenon. We don't know why some people are prone to it and others are not. But most of us are not prone to addiction. So in cancer pain management, we really don't think of that as a major problem. What we really want to do is, if we see it, we'll certainly deal with it. But most people can take opioids and not become addicted. If we think about side effects, these can be really miserable. Constipation especially, it can be just a life-changing negative event from opioids, and opioids are very constipating. Other side effects: dry mouth, nausea, drowsiness, confusion, tolerance, physical dependence. And if we think about opioids for chronic pain, about 25% of the patients that we have in the pain clinic on opiates, whether it's cancer pain or non-cancer pain, misuse opioids. They take too many, they run out of drugs early, they want more. Their behavior changes because they have an addiction issue. That means 75% of our patients on opiates don't misuse them. About 10% really develop an overwhelming addiction. And 5% of pain clinic patients on opiates transition to street heroin, but that's a rarity. If we look nationally, and this data is now pretty prevalent because of the opioid crisis, everybody's looking at this with a microscope. There are about 9.4 million Americans who take opioids, but only about 2.1 million of those are considered to be addicted to these drugs. That means millions of people take daily opioids for chronic pain, whether it's cancer pain or not cancer pain, without addiction. And in 2012, at the kind of the peak of the opioid crisis, there were about 260 million opioid prescriptions written in the US. And overall, of all those prescriptions, there were 16,000 deaths. And of course, one opioid death is too many, but there are many millions of people who take opioids who don't die, who don't overdose, and who really have a better quality of life because of these drugs. So, interestingly, when a patient comes to a doctor with cancer pain, doctors think differently when we're dealing with cancer pain versus chronic benign pain. Like, let's say somebody has back pain from 5 back surgeries. We really are loath to start that person on opioids. If someone comes in with cancer pain, especially if it's progressing, that's the first thing we think about. Let's get this patient on opioids so they can get good pain control. So in general, doctors are much more liberal and open with opioids in cancer, but there are really different types of cancer pain. So of course, pain of terminal cancer, I think all of us would agree, addiction is not going to be an issue. If someone has 6 months to live with advanced stage 4 cancer, we want to keep them comfortable and we're not going to worry about addiction. But what if that cancer is controlled and it's going to perhaps be in the background for many years? That patient is really more of a chronic pain patient than a cancer pain patient. So there we have to be a little bit more careful with opioids. And then there's the cancer that is either in long-term remission or has been essentially cured. Those patients really are more like the chronic pain patients that we see in the pain clinic. There we would like to not use opioids for 20, 30, 40, 50 years. So in getting back to this idea that when you have cancer that's advancing, we're much less concerned with addiction, and we really want to relieve pain as the prime concern. So just to kind of end my spiel on opioids, opioids are safe and effective for some patients, but they can be destructive and even fatal for other patients. 20% of the population has an addiction propensity. But all systemic opioids have mental side effects. So let's say someone is taking these medications for pain relief, they're getting reasonably good pain relief, they're not addicted, but they're just probably not going to feel that great. They're going to have this drug in their brain 24/7, and it affects the way that you think and the way that you react. If you're driving a car, your reflexes are lower. There's about an 8-fold increase in car accidents in people on opioids. So there are lots of mental effects that patients sometimes are not even aware of, but they do have an effect on the way that you think and live. And some patients are just sick of drugs. They don't want to take 20 different pills a day. They don't even want to take one pill. So what are the alternatives? That's really where pain clinics and pain specialists come in. We try to give patients alternatives to opioids. And in our clinic, we use what we call multidisciplinary interventional pain management. So interventional means minimally invasive procedures to diagnose and treat pain. And as an anesthesiology pain specialist, that's what I specialize in. I do X-ray guided procedures to block nerves, to put medicine on certain painful structures so that patients don't need to take narcotics or other drugs. And our goals are to coordinate medications with these minimally invasive procedures and with physical therapy and behavioral health. Behavioral health is psychology type interventions to give the patient a more overall broad pain relief without relying just on narcotics. And we like to reduce opioids to the lowest effective dose. And that's true for cancer pain and for chronic benign pain in the pain clinic. So if we think about physical therapy, I think it's always an important adjunct to opioid management, whether it's cancer or non-cancer. In our clinic, we use lots of PT, we have a pool, and we think that's really good for the patient's overall quality of life, to get them moving and exercising and as active as they possibly can be. And certainly behavioral health is a very important part of pain management in many patients, whether it's cancer pain or chronic benign pain. But in cancer, a cancer diagnosis is it's a very life-changing event, and it can create severe anxiety, depression, and mental anguish. And emotional suffering can manifest with the same type of behaviors as physical pain. So sometimes it's hard to tell when a cancer patient is suffering how much of that is physical versus this mental anguish that they're feeling. And sometimes everything is all mixed up together. It's hard to separate. But in our clinic, of course, for sure, we think treatment of this mental anguish and suffering is equally important to any physical pain relief that we're giving. So we are always thinking how much of this is physical, how much of it is psychological, and we try to get our team of psychologists and behavioral specialists involved in management. We have a chronic pain program. We have psychologists who do individual counseling, and we think that's a very important part of pain management overall. So on to interventional procedures, which is really what I specialize in. This is what I do most all day long in the pain clinic. I'm using fluoroscopy, which is a real-time X-ray, to place needles and other and things like spinal cord stim wires or pain pump catheters into certain parts of the body typically under local anesthesia, IV conscious sedation, or general anesthesia to make these interventions painless, or as painless as possible. And that's where we can really get in, and if there's a certain pain generator, we can identify it and we can target it. And that's sometimes the most important thing to do for cancer pain, especially if it's invading a nerve or if it's something that's amenable to one of these procedures. And we're doing things like blocking spinal nerve roots. We do things like celiac plexus ablation. This is especially helpful for pancreatic cancer with severe abdominal pain, because all of the abdominal nerves are going through this one nerve headquarters called the celiac plexus, which is easily acceptable to our needle, and we can block it and we can ablate it to knock out abdominal pain that's even very severe and requiring high doses of opioids. When we do this procedure called a celiac plexus neurolysis, patients can get off of opioids and not have any abdominal pain. Vertebral body fractures are another good indication for what I call interventional pain management. And here we're doing something called vertebroplasty or kyphoplasty, where we place a special needle into the vertebral body, deliver cement, fix the fracture, and we can take pain away pretty immediately. So with this procedure, patients are in severe pain, they can't stand, they can't walk, they can't sleep. We do the procedure, and in the recovery room, their pain is gone. It's quite amazing. So rather than cover up that pain with high-dose opioids, we'd much rather fix the problem with some minimally invasive procedure. And to finish up with this whole idea of interventions, I want to talk a little bit about neuromodulation, because that is where we would go when nothing else is working and the pain is really out of control. And neuromodulation, what we're doing is we're using the spinal cord to relieve pain. And we're either targeting the spinal cord with electricity to block pain, That's what neurostimulation is. Or we're sending medications to the spinal cord to block pain. And the idea there is block pain at the spinal level and keep the brain free from any drug effects. So with neuromodulation, we can create very powerful pain relief without affecting mental processes. People don't have foggy brains. They can think straight, they can drive, they can do everything that they want to do and be a normal person without drugs in their brain, because we're focusing on the spinal cord for these types of pain relief. And in the simplest form, think of labor epidurals. So as anesthesiologists, this is what we do in training and in practice. We put epidural catheters into patients who are in labor, and think about how intense labor pain is. We can block it completely. Patients can deliver babies with no pain with an epidural. And that is kind of the simplest form of neuromodulation. And it creates very powerful regional pain relief of the abdomen, or if we put the catheter into the epidural space of the cervical spine, we could block any pain from the head and neck. It's extremely powerful. We can even create surgical anesthesia with an epidural. So we deliver bupivacaine to the epidural space, we can do surgery and the patient doesn't feel it. So it's extremely powerful. The problem with it in practical pain management is that an epidural system requires high volumes of medication to be effective. So if you think about a woman in labor, they're walking around or in bed with an IV pole, a liter bag of local anesthetic, and an external pump that's infusing that into the epidural space at about 10 or 12 cc's an hour. So in one 24-hour period, they're going to use 2,000 cc's of fluid to keep their pain relief going. And in the hospital, that's fine. You know, they're going to deliver the baby and they're done. But for things like cancer pain management, it's just not practical. Nobody wants to walk around with an IV pole and an external pump, even though it's great pain relief, it's just a huge hassle. So if we think about the anatomy here, I just want to explain the difference between epidural and intrathecal. So the epidural space is inside the spinal canal. And the spinal canal is a tube that runs from the skull to the tailbone, and it transmits the spinal cord and all the spinal nerves. And if we place a needle into the epidural space, we can put an epidural catheter into that space. And this is a diagram of that catheter. It's going into the epidural space and infusing local anesthetic. Now, this is the same space that we place a neurostimulator wire, and we deliver electricity to the spinal cord. And we're on top of the dura. So that green area there that I just highlighted, that's the dura. Beneath that is the water of the spinal fluid. That's where the spinal cord is. And the CSF, the cerebral spinal fluid, bathes the brain and the spinal cord in this water environment. And beneath the dura is the water of the spinal fluid. If we stay outside the dura, we're in the epidural space. So if we think about how we use this in the pain clinic, neurostimulation is, like I said, delivering electricity to the spinal cord. And these are epidural systems, very similar to a labor epidural catheter. It's just not delivering medicine, it's delivering electrical impulses to block pain. And we can target various parts of the nervous system with electricity, and we can, with certain types of neurostimulation, we can target body parts like a foot or an ankle. This is a lady who has complex regional pain syndrome, and we might want to put a what we call a dorsal root ganglion stimulator in to block pain at that leg. If someone has more diffuse pain, it's in their entire lower back, both legs, we might put spinal cord stimulation wires in, either in the thoracic or cervical spine. But for cancer pain, it's often not the greatest option. It's not quite as powerful as medication delivery to the spinal cord. And it's very good for what we call neuropathic pain, meaning nerve injury pain, but it's not great for nociceptive pain. And cancer pain is often a mixture of both. So we have these inflammatory cancer pain problems, and we also have these nerve cancer pain problems, and they're all kind of mixed together. And a neurostimulator really doesn't address the nociceptive part of that. That's when we turn to what we call targeted drug delivery, or a pain pump. And this is kind of where we go when nothing else has worked. And it's what I think is the most powerful and helpful pain relieving system ever invented. And it's perfect for cancer pain that's out of control, that hasn't responded to anything else. If we think about where we're putting this catheter, we go through the dura into the water of the spinal fluid. Now that catheter is going to put medicine right onto the spinal cord. And it's extremely powerful at very low dose. So if we think about an epidural catheter, I said we needed about 10 cc's an hour to create pain relief. With intrathecal drug delivery, when that catheter is in the water of the spinal fluid, we can get by with 1/2 of a cc in 24 hours. Think about how tiny a dose of medicine that is. It's just a little drop, but it's enough to create very powerful analgesia for 24 hours. And that's why a pain pump can be implanted into the body completely under the skin, because a pain pump might hold 20 or 40 cc's of medication. If we were running that in an epidural, it would be gone in 6 hours. But since it's going intrathecally onto the spinal cord, it can last for 2 months or 3 months. So typically, a patient who has a pain pump might have to have that pump filled with medication every couple months, 8 weeks, 12 weeks, whatever. And that's why the pain pumps work so well. So what we're doing really is we're placing the catheter onto the spinal cord, and we're putting medicine there 24/7. And what medicines? Well, we can use opioids and local anesthetics. And that's typically what we do in our clinic, is we combine the two drugs. So if we think about a labor epidural, that's essentially a local anesthetic. If we combine that local anesthetic with opioid, now we're blocking pain from two completely separate pathways, and it's extremely powerful. That's why pumps work so well for just about any type of pain. We can also use baclofen if there's spasticity. Clonidine is what we call an adjuvant drug, and Prialt is a newer drug that we sometimes use for severe nerve pain. So pumps are delivery systems, and we can put various drugs and mixtures of drugs into that pump to tailor make a pain relief concoction for the patient's particular needs. And this is a typical pump system, basically. It's the pump itself, which is, can you see my, let's see. Well, you can see the big circle there. That's the pump itself. That's implanted under the skin, typically in the abdomen or the upper buttock. It's filled through that central port. So every few months, we take a needle, anesthetize the skin, put it into the pump, fill it up, and it's good to go. And the pump is three things. It's a drug reservoir that holds that medication inside of it for months. It's a pump that delivers the medicine 24/7 in the background. And it's a computer that we can program to deliver the medicine any way that the patient wants it. So some patients want to control their pain. They want to push a button on an external remote and get a dose of medicine when they're having pain. And when they're not having pain, they don't want to push the button. They just want to have really nothing going. So that would be one way to set up the pump, is just give the patient the ability to self-administer bolus doses during the day, once a day or 20 times a day, depending on how we program it. Other patients don't want to mess with anything outside the body. They just want the pump to deliver the medicine 24/7. They don't want to think about it. In those patients, we turn on the infusion at relatively high dose, so it's giving the patient drug all day long, and they don't have to think about it. So it's a very flexible platform that we can tailor make to the patient's needs. And this thing on the right here that says Flowonics, that is the programmer that the patient would use to give themselves doses as needed during the day. So if we just summarize, what are pain pumps? They're computerized delivery systems that have the ability to deliver continuous spinal infusions and or pre-programmed patient-administered bolus doses of medication directly to the spinal cord, keeping the brain free of drug effects. That's what a pain pump is all about. And this is just a diagram to explain that any route of administration of opioids, whether it's pill, injection, intravenous, or skin patch, it's all going to go into the bloodstream. And the bloodstream takes that drug and puts it right into the brain cells. And that's why opioids are a problem, in that they're creating all these mental effects that people don't want. They want to be awake and alert and be able to think. And if you're taking these drugs by any route other than the spinal route, it's going to your brain and it's going to affect your mental abilities. Spinal administration is different. It's unique. It's putting the medicine on the spinal cord and it's keeping it there. And that's the beauty and the power of it. It's very powerful analgesia without mental side effects. And this is a patient who I implanted with a pain pump. So there you can see the midline scar in the low back. That's where the catheter goes into the spine, and we anchor it there. And then the catheter tip, we place at the area of maximal pain. So let's say this guy has pain up in his neck and shoulders. That catheter tip would go up there at maybe the bottom of the neck where his pain is most intense. It would put the medicine at that point, and it would be most powerful there, but it would spread up and down the spinal cord. So it would block pain in the lower body and the upper body with one system. If this patient just had lower body pain, we would put the catheter lower into the thoracic spine. And the pump itself is right there. So it's under the skin. You can see a little incision there. That's a 40 cc pump. And it really is buried. It hides there very well. You can see that it's really not cosmetically even that visible. So this patient is, he does not have cancer pain. He has chronic benign pain, but it's the same system that we would implant for cancer pain. But he basically goes about his business. He works, he drives, he functions, and he uses the pump as needed. This is just one of my last slides. We've done a fair amount of research on what we call targeted drug delivery, and we have probably one of the busiest pain pump practices anywhere in the world, partly because Medtronic is here and so is Flowonix. So both the big vendors of pump technology are in Minneapolis. And I've been interested in pumps since the early 1990s. So I've become, very enamored with this therapy, and I use it a lot. And so we've published, and this is the most recent article that we published back in spring of 2020. And it's basically what we did is we sent a survey to our 600 patients who have pumps. And I asked 20 questions. I said, what do you think of your pump, basically? Does it help you? Are you taking less narcotics? Are you going to the emergency room less? Are you seeing your primary care doctor less? Is your function good? Do you like the pump? All these questions. And the reason I did this survey is because over the years, when I would implant either a neurostimulator device or a pain pump in a patient, I would ask the patient over, months and years, what do you think of your system? And patients with neurostimulators say, it helps, I think it's okay. When I would ask a pain pump patient that question, they would say, this is the best thing I ever did. I couldn't live without it. And we don't hear that from chronic pain patients very much. And so I thought, it's very interesting. I kept hearing that over and over. So I wanted to quantitate it, and that's why I sent out this survey. And it was really quite telling. It was overwhelmingly positive. Patients love their pumps. They just think they're the greatest thing. And not everybody, but most patients say, I would do it again. This is the best thing for my pain management, much better than pain pills. And this is the last slide, but these are just individual comments, because we had a free text thing in the survey. We said, tell us what else you think. Because we thought maybe people would say, I hate the pump, or it's doing this or that, but most everybody was saying, wow, this is great. So these are just comments that we had from our survey. And we published this, and it's out there in the journal Neuromodulation. So anyway, that is my spiel of simple to more advanced, pump being the most advanced, neurostimulators being one step back, and medications, including opioids, being at the beginning and perhaps the best thing for most patients with cancer.